So, without a doubt, the question I get more than any other question, bar none, is why does my blank hurt? And it's a very multifaceted question. So, I'm going to do my absolute best to take you along through the journey of what's really going on inside my head as somebody's asking me questions like this. Hey guys, my name is Dr. Joseph Rosie. I'm a physiotherapist, strength coach, and the founder of Linear Performance. And today I want to talk about everything about pain. Right? I want to talk all about pain and everything that really goes through my mind as a clinician in regards to why somebody might be having pain, what they're feeling, why they're feeling it, and then how we're really going to focus on addressing it. So first and foremost, when thinking about pain, it's first of all, is pain coming from that site, right? So let's say, my shoulder hurts here. And it's like, okay, well, is pain coming from right here or is it referred? The way we're going to find out if it's coming from there is kind of like poke the bear. So if my shoulder, or let's say even like the tricep area here hurts, if I'm pushing on it and it's making it worse, then we can understand that yes, that is where the site is. However, if it hurts here and then we start rubbing it and we start, rubbing it, doing some sort of massage or whatnot, and it feels better, then we can almost always understand that that's not actually the source of pain and it's probably referred somewhere else. So what I want you to understand is if wherever you're talking about hurts, if you touch it, if you move it, if you do something there right then and there and you poke it, if it does not feel worse immediately right then and there, then the pain is actually referred somewhere else. And that's really where there becomes so much overlap between so many professions, and this is why so many professionals, even within the same profession, can't agree on something, yet alone multiple professionals from different professions. So when it comes to referred pain, I like to think of this as the Tomes family, right? So we can have referred pain for a number of reasons. So the one that most people, jump to the conclusion to is nerve root, or what's called a dermatome. And dermatomal pain patterns are very common. You can see them all over the internet. Most medical practices will have a picture showing these referred pain patterns, on the wall. The thing is, it's very few and far between to actually follow that pattern. But at the end of the day, it's a pain that is arising from the nerve root. So if you can imagine the spine, anything that is encroaching on that space, that's causing inflammation, etc., in that area can be causing that nerve root pain. Now, when somebody has pain like this, they're typically going to be talking, and you'll be hearing them when they say how it feels, that it's stabbing, it's jolting, that it's like lightning in nature, and you're going to hear some of these things. Right? Another one is myotomal, right? Meaning muscle. Okay, so this is where pain is going to arise from the muscle itself. And what's really cool about this is the way that this was found out is by essentially injecting muscles and then seeing, asking people, where's it really hurt? And then you just do this so many times and you see there's common referred pain patterns. Now, the crazy thing about this is it's very hard to understand this one because you cannot see it on any image. And for that reason, a lot of people will neglect if somebody has or says they have pain because they will do a whole, workup of all these tests, images, X-ray, CT, MRI, and they won't find anything. And the thing is, it's because you're not really going to find an issue within the muscle itself on an image, right? But you can absolutely have, myotomal pain and muscle pain, right? That will ultimately, you find that a lot of people end up saying that it's feeling crampy, or even sometimes it's really tight. It's just like that constant debate. Now, the thing is about, myotomal pain is I find that this is more of secondary to another reason. So the third one I want to talk about is sclerotomal pain. And this is, in my opinion, by far the number one reason people actually do experience pain. So when it comes to sclerotomal pain, think of this as like the ligaments, the tendons, the joint capsules, where those tissues all attach to the bone, those sites. And that's where most people are going to complain of that deep burning, that dull ache pain. And that is by far, as a musculoskeletal expert, that is by far the number one complaint that I will hear when people come see me in seek of conservative care, either pre or post-operatively. Now, when you do this long enough, you really see that that sclerotomal pain, that ligamentous tendinous joint capsule pain can come from a number of reasons. It can come from lack of use or very much overuse. And you see that in both ends of the population that I really work with, the high-end athletes, the gym goers that are going all the time and they're really pushing their body to the limits. And the same, or the other end of the spectrum, where people are more sedentary and they're not really using it. And then they go out and maybe do something with their family, say they go to Disney World, and they use a lot of these tissues a lot more than they're used to or accustomed to, or do something like partake in like a 5K or something like that. And you have an acute increase in that loading. which can ultimately lead to somebody experiencing some of this pain. Now, the fourth one is viscerotomes, and that's really where pain arises from your viscera. Now, this one is one that is not the most common that I will see, right? Most people, if they're having complaints like this, then they will end up, typically going to see, primary care physician. What's crazy and funny at the same time is this is the number one thing that people say in fear of why, clinicians that aren't predominantly a physician or primary care physician is the reason why you need to go see a primary care physician first, because they feel that they are the best ones to recognize this. And I say this because all areas of your viscera typically are going to refer to your low back. So if you look at like these referral patterns, and I'll show you here in a second, that so many of these referral patterns actually overlap each other. So it's no wonder we can't even, come to the same conclusion of what's really going on, right? And then the last one is going to be thermotonal, right? And that's going to be the temperature. So think of blood flow and circulation. Typically, when somebody's having an issue here, they're complaining about something feeling like it's throbbing. It's throbbing in nature. And you see this all too often in somebody who has, vascular insufficiency and they have blood pooling in their legs and they can't get it up to their heart to circulate. And they always feel like their feet and everything are just throbbing all the time. But you also see this in, after acute injuries where, say you tore a muscle or a tendon in your arm, you're getting, so much inflammation in that area and it feels like it's throbbing. And that also can be a circulation issue as well, because there's so much swelling that it can't occur. So that's why sometimes, depending on where the nature is, if it's acute, subacute, more chronic in nature, it can be even hard to understand where the pain, where the symptoms and everything are arising, what the true tissue-specific pathology is, because so many things can actually be clouding the judgment of really what's going on. Now, as a clinician, as a therapist, I get the privilege of working with people for a little longer than only seeing them for 5 minutes, which makes my job easier, because sometimes what I think on the first day, I completely change how I feel after, a day, 2 days, a week, or even a month at times. It really does depend, because every single person is different in this nature. So when it comes to those things, it's like, okay, that's great information. Your pain can either be at the site or referred. How do we know? Well, really, we're going to know by stressing these tissues and seeing what makes it worse, okay? So by actually figuring out what makes it worse, then we can actually know what's the irritating tissue. And the thing is, by stressing it, it has to be the same pain that you're feeling. It can't just be like, yeah, that hurts. It has to be the same exact pain, right? Now, when it comes to an injury, we have in our body what's called a mechanoreceptor. And these receptors are everywhere, and they are designed to sense change, right, in pressure. Change in temperatures, things like that, right? When we have those changes in these receptors, what happens is that sends a signal to the neuromuscular junction. And that neuromuscular junction is then going to send a signal to the muscles in order to respond. Now, when there is a faulty signal, right, which happens with injuries, then we're going to get a bad signal sent to the neuromuscular junction. Therefore, we're going to get a bad response from the muscles, right? And this happens all too often when we have a poor coordinated muscle response from something or someone when they've hurt themselves. Everything feels a lot tighter. Everything feels way harder than it used to feel. And because we're having that poor signal, which means it's going to feel, or it could feel like you're trying to pick up 500 pounds. In reality, you're only trying to pick up 2, right? Now, if we get that poor coordinated signal, what that can lead is to some reactions. And those reactions might be, increased inflammation, increased loading of certain structures, which will lead to even more inflammation and can lead to even chronicity of symptoms. The thing here is how it comes really treating. And that's where so much of the thought process differs person to person and profession to profession. If you sit there and just treat the results, right? Treat the inflammation, treat some of this, then sure, you might be putting a Band-Aid on it, but you're not really treating the original injury, the original cause that's creating that poor signal, that's creating that, uncoordinated muscle response, that is ultimately creating increased loading, which is creating more tissue inflammation, that has ultimately led to the chronicity of symptoms. And that's where I think as physios, we shine above all else bar none, because we're able to truly sit back and take a look at all the pictures and bringing them all together and not focusing too much on one piece of information, aka like an image, a CT scan, an X-ray, an MRI, and focusing more on the entire picture and taking somebody's perception, somebody's pain response into account. Now, if somebody were to ask me like, how do you treat it? Well, the thing is, you're going to treat every single one of those issues I just talked about with muscles, right? The intent of all of it is going to absolutely change. For example, if I have somebody that has nerve root compression, right, that's following a dermatomal pattern, right, so therefore they can have pain down their arm, down their leg, etc. I'm not going to treat the arm and the leg. I'm going to treat the back, right? I'm going to treat the nerve root if that is truly what I believe it to be. So depending on where they are in that, acute, subacute stage, if it's in the beginning, what I want to do is calm down everything and give everything a little bit of breathing room. So what I might start with is some positional distraction. And I might open up that area to give it more room so that way there isn't that compression, that irritation. Then what I'll do is move to finding a way to get the muscles to actually coordinate and maintain that positional distraction. Right? And here's where things get really interesting. So as I was talking about how you can have the injury, the issue to the mechanoreceptors that send the faulty signal, and the signal gets sent to the muscles to have a lack of coordinated response, we can then address that coordinated response and then try to rearrange that so it's getting the appropriate response even though it's getting a poor signal. And if we can even start cutting off this chain reaction, maybe not at the very front of it or the end of it, but somewhere in the middle, we can even get that much closer to getting to the true cause and addressing that. So when it comes to, say, the nerve root, or in this case, let's say the nerve root, we have to think, what are the tissues, the structures there that could be causing the pain? And it's almost always going to be ligamentous in nature, right? Because if we look at the spine, there's so many ligaments wrapping around the spine itself. We have the ligaments, and then we have the muscles that control it. Well, the ligaments aren't going to change of what they're doing unless there was a major injury. The muscles are only responding in response to the signal that they were given. So we almost always have the issue being at the ligaments, and we are addressing it with the muscles. Now, and this is going to look different for everybody, because if somebody has so much pain that we can't address what we need to, then we have to trump addressing what we need to in order to address their pain, so then we can come back and address what we need to. I know it might sound funny, but it just really depends, and every single person is different. It's not black and white, and I think a lot of people would like it to be. It would make everybody's job easier. However, if it was truly black and white, I think we would take so much more of the human aspect that has already been taken out of the process. But if we're looking at myotomal, right? Let's say it's the muscles in question. Almost always how we're going to address it is really focusing on increasing, first of all, decreasing the signal, the faulty signal, but then increasing the muscle strength and the endurance and the coordination. And it's almost always one of those, or all of those. All too often when we have a muscle that feels overly tight, when that feels overly crampy, it's because it's working, if you can imagine, at the higher endpoint of its capacity. So let's say, if I had to, say, open a door. And if I had to open a door, and let's say the door is approximately like 6 pounds, right? I'm using, my biceps, the back of my arm, back of my shoulder, and my trap, or lats, all of this to pull. Well, let's say the door is 6 pounds, but I'm, I can, move, say, 100 pounds. Well, I'm effectively only working at 6% of my overall capacity. I can do that all day long. Well, the same thing happens, or think of it in another way, where if somebody isn't that strong and they're working always at their upward limit, let's say the door is actually now 90 pounds, or let's say it is 6 pounds, but your capacity is only 10 or 8, right? You're now working at 60, 80% of your capacity than if you were much stronger. And all too often, that's what I find, is people are constantly, working at a high level. And the easiest way I typically will explain this to people is, imagine if you had your car, right? And you have, your drive automatic, and it's constantly changing when you get to 3,000 to 4,000 RPMs. But imagine if it wasn't, right? Imagine if you're redlining it like the entire time. Well, how long can you do that before the car, in that case, is actually going to break down physically? Well, the same sort of process can happen to the body. And I'm not saying that the body's physically breaking down. However, it is getting overworked. And when it's getting overworked, then it's not getting what it needs. So it's almost like a conundrum, because it's kind of overworked, but the way we're going to actually fix it, and often a lot of times, is actually get it stronger. Therefore, it's not working at the upper limits of its capacity. So that one's always a fun one to work with. And I can keep going down through every single one. With sclerotomal, with being the ligaments, the tendons, joint capsules, really at the end of the day, it comes down to remodeling those tissues and by stressing them. So in order to stress a tendon, we have to stress the muscle, because the tendon connects the muscle to the bone. And to do that, we have to overload the tendon more than what it was already accustomed to, which means we have to, use a heavier weight, more time under tension, more resistance for a longer duration. And for a ligament's job is to bring bone to bone. Well, if we have a ligamentous strain, right, and let's say it relaxes or it's torn or strained or what have you, that approximation is now going to increase. When that increases, what happens are the muscles, in this case, are going to feel like they need to take up the slack. So what they do is they approximate everything. And everything starts approximating more and more, and it starts holding on. And that ultimately is where people are feeling this pain, feeling all these issues, etc. And that's where they feel that constant, like, dull ache. And it's really because these muscles are working all the time when they really shouldn't have been. Now, the end fix for that will be kind of similar, right? So what we want to do is tone everything down and then get that muscles to be have higher endurance first and foremost, and then in coordination to coordinate with its synergistic muscles, its partners that are going to help it, and then last but not least to get it stronger. But at the end of the day, how we fix any of these are almost always going to be targeting in one way, shape, or another the muscles. You know, what I've seen with working with so many people over the years is, first and foremost, the primary injury that most people are ever going to experience are going to be that sclerotomal, right? So think ligamentous tendinous joint capsule. That's by far, the highest level of injuries and where they're coming from. We often end up having to treat muscles secondary to, poor muscle response from that primary injury. Then after that, it's really just figuring out and helping somebody along the way and being able to communicate it in such a way. What you find all too often when somebody comes in, they're complaining of their pain, they're complaining of, what's going on. And you can find out pretty quickly that some people don't feel satisfied with what you're telling them. And what they'll end up doing is kind of go into like doctor shopping, and they kind of keep going around and looking for a different answer. And that's really hard because in order to address any of the things that I'm mentioning here, there are some things that you can make a quick change, right? And those quick changes can relieve symptoms fairly quickly. However, to have any long-term lasting result, it's going to take some time. And realistically, we're looking at about 3 months, for most of these things. We're looking at a 3-month time frame to see any major changes, right? And you should be able to find little changes along the way. And that's, in my opinion, the most rewarding part of the profession is helping somebody along each one of those changes in helping them along the way to be able to see that. So I just wanted to come on real quick and just talk about, pain a little bit, because all too often, people are wondering where the pain's coming from. And what I find more often than not is the pain is coming from some separate source than where people are feeling. So first things first, bar none, is it coming from that area or is it referred? So if it comes from that area, just understand anything you do should make it worse. If it doesn't make it worse, then it's not coming from that area. And that's where sometimes you will see that somebody will go to, say, massage therapist, acupuncturist, chiropractor, or even a physio at times, and they'll sit there and have them massaging their arm, right? A common referral pattern after a rotator cuff injury is down the arm here. And they're rubbing it and like, that feels better, but it's really not going to make any difference because that's not where the pain source is. Remember, it has to make it worse. Where the pain source is actually going to be right up here, right? This is your sclerotomal pattern that is going to be where that tendon connects to that bone, and that deep layer, or that outer layer of the bone, is what's causing the referral pain pattern down here. The more irritated it is here, the further down the arm is going to go. So all too often, I'll hear and see somebody's like, they're rubbing their arm, they're trying to address this here, and it's like, that's not where the pain is coming from. It's truly coming up from up here, and that's where we need to address. And some people are completely amazed that you're the first person to be able to even recognize that, and some people are just completely put out that you think that the pain is not where they are directly pointing to. So it's always fun, working with people and trying to be able to get ahead of them and get in front of them in a good way that's both empowering and enlightening to them at the same time. So I hope you found this video helpful. If you did, do me a favor and subscribe to the channel, leave any comments below, and I'll see you in the next video.